Good afternoon. Welcome to today's Grand Rounds presentation. Please remember to sign the attendance record, get credit for being here, and also please fill out the program evaluations. And if you could give us ideas in regards to future topics, future speakers, we'd appreciate that. Speaker today is Dr. Suman Nalluri. Dr. Nalluri is board certified in neurology and also did critical care neurology training at Washington University. He's here today to review red flags in regards to neck and back pain evaluation. Please join me in welcoming Dr. Nalluri.
Thank you, Dr. Halbert. Today I'm going to talk about neurological causes of back and neck pain. This topic is mainly going to be from neurological standpoint. I'm not going to discuss about the other causes like aortic dissection or any other systemic causes of back or neck pain. This is going to be purely neurological. And also the purpose of this topic presentation is mainly to identify the neurological causes of neck and back pain, so that because the spinal cord and nerves are vital tissues, and the damage to these spinal cord and nerves can lead to disability and significant morbidity and mortalities. So I think recognition of these problems is important. And the causes of neck and back pain, actually the majority of the causes are non-neurological, like injury or damage to the spine and its supporting structures, like the facet joints. Here you can see the vertebral body, the bone, and then you can see the joints between the superior articular process and inferior articular process. There is facet joints and the ligament damage. So it's mostly a musculoskeletal causes account for the majority of the back and neck pain. But sometimes when these things, when they become too like arthritic or degenerative joint changes, and that can sometimes compress the nerve or the spinal cord, and those things can have severe consequences, and sometimes those could be irreversible, leading to significant morbidity. And I'm going to talk about how to obtain a proper history from these patients who present with neck and back pain, and also how to perform an examination. Then I will talk about which patients need to have an emergent referral or which patients can be observed. So let's start with the history. So when obtaining history among these patients, the first thing we need to do is, since how long they have the symptoms, whether this is a acute, like a sudden onset of the pain. In those cases, if there is trauma, as can happen with motor vehicle accidents, flexion extension injuries, whiplash injuries, blunt trauma, lifting, straining, all those traumatic causes. So those things can lead to acute onset of the back and neck pain. And so in obtaining history, when you ask the patient, since how long you have the symptoms, if they say it started pretty suddenly, then you need to think about whether there is any trauma. But there is some non-traumatic causes of sudden onset of back and neck pain too. And then if it is an ongoing, like it's going on like for a few months, or then you think more about like a degenerative process of discs, facets, or myofascial elements. But those things are also usually brought on by some kind of a mild trauma before. So in obtaining history, the first point is since how long they have the symptoms, that will point to some of the etiologies. So as you can see here, acute onset of the back pain or the neck pain can be from herniated disc. We talked about trauma, but there is some non-traumatic causes like herniated disc, but herniated disc can be because of a mild trauma. And there is some non-traumatic causes like spinal AVMs, spinal tumors, epidural mass or infections can cause acute onset of the back and neck when the patients can present that way. Whereas subacute, the most commonly we see like a tumor or mass or infection, And there is, transverse myelitis sometimes can present subacutely. And then usually the chronic things are because of the degenerative changes like cervical or lumbar stenosis or a tumor. So sometimes these things can present acutely, or sometimes they can present ongoing problem for a few months or something like that. But the most common causes that causes neurological component of the pain is from these herniated discs or tumor, mass lesions, infections. Those are the main things. And also when obtaining history, we have to ask for whether the pain is kind of persisting at one side, whether that is a local pain or whether that is a radicular pain. Is the pain going into the arm or pain going into the leg from the back? Those radiation of the pain can be a referred pain, because the spine can actually has the pain that comes from the spine can go on and present in a dermatomal fashion, which is called referred pain. But sometimes the compression of the nerve root itself can cause a radicular pain. So there is a radicular pain and referred pain. And then local pain is usually because of a local tissue damage. It could be a ligament, facet joint, or bone. So the first thing is, since how long the pain is going on. The second thing is whether that is a local process or whether there is a radiating nature to the pain. And also when there is a nerve root compression, they will have more severe pain, and they will have pain more distally. If it is a neck pain, the patient can have pain all the way going into the fingers. And if it is a back pain, they can have the pain, the radicular pain go up to the toes. So depending on the nerve root compression, which nerve root is getting compressed. The third thing is aggravating and alleviating factors. So usually when there is a nerve root compression, the patients will have worsening of the pain with increased intraspinal pressure, as happens with coughing, sneezing, straining, or Valsalva maneuvers. And also with upright activities, they will have more pressure, more pain. Whereas if the pain is coming from the local musculoskeletal injury, they don't have that worsening with these maneuvers like coughing, sneezing, straining. So you have to ask the patient whether the pain is getting worse with these things. And also, if the pain is if it is from radicular or spinal origin, either the musculoskeletal damage to the spine or compression of the nerve root, though that pain usually gets better when they lie down in the bed or when they assume lateral or fetal positions. But if it is something coming from the viscera, or that pain doesn't actually get better even when they are lying down, like a localized processes like pathological or compression fracture, infection, they don't get better. And in some patients, actually, the pain is worse when they are lying supine, as happens with extramedullary tumor with the spinal fluid block. So the main point here is whether the patient has worsening of the pain with these aggravating factors like coughing, sneezing, straining, and with prolonged standing positions, then that is most likely a radicular pain. If that doesn't happen like that, that could be because of pain coming from the viscera or from a local pain. And then we ask for specifically whether there is any nerve compression. So we ask for nerve-related symptoms like weakness, numbness, or radiating pain. And if it is the spinal cord compression, if you are suspecting, then you should ask for whether they have difficulties with walking, bowel bladder problems, erectile dysfunction, or is there any numbness at any particular level. So in obtaining the history, I think the first thing is since how long the pain is going on, and the second one is whether that is kind of a radicular pain going into the distal extremity. The third thing is whether that is getting exacerbated by these coughing or Valsalva maneuvers or with prolonged standing. And then you have to look for neurological symptoms like sensory loss, weakness, bowel bladder difficulties, walking problems, and also the last one, this is one of the most important things, whether the patient already has a diagnosis of cancer or malignancy or HIV or immunosuppression, because those patients are at high risk for an epidural abscess, or the malignancy patients who already has a malignancy are most likely can have a metastatic spinal cord compression. So in obtaining the history, we need to look into those factors too. And coming to the examination, as with any examination, first thing is inspection. Look at the spine to look for any spinal deformities, because sometimes the fractures, those things can cause spinal angulation, short spinal angulation. And look for midline dimpling, as happens with spinal dysraphism. And you can look for the curvature, looking for scoliosis. Those are the important things when we are examining the patients. And then palpate for any muscle spasm or any specific points of tenderness or sciatic notch tenderness. And then we can do light percussion to see whether those joints are much more painful. And then assess the range of motion of the spine, like flexion, extension, lateral bending, and rotation. And the next part is mainly the neurological exam, as we do with every patient, the motor examination to assess the strength, the tone, the reflexes, and sensory examination to look for any particular distribution of sensory loss, or whether they have a level, a spinal cord level up to which they lost the sensation. So sensory examination, motor examination, checking for reflexes, and a rectal examination to evaluate for sphincter tone. Those are the important things in the examination. And then we have to assess for gait, whether the patient has any spastic gait, and also we can assess walking on the toes and heels, as walking on the toes can be difficult in patients with S1 radiculopathies, whereas walking on heel will be difficult in patients with L5 radiculopathies. And spastic gait is basically stiffening in the legs, and they have like a scissors gait, like both the legs kind of come together because the adductors in the adductors get kind of stiff and can bring both the knees towards each other, and they will have scissoring gait. And when they are walking, they have like more circumduction at the hip. So that spastic gait that happens with a spinal cord compression. So in neurological examination, we have to just follow, as with every patient, motor examination, sensory examination, reflex changes, and gait, look for spastic gait, and also check for toe and heel walking. And if you are suspecting some problems like a conus medullaris compression or any spinal cord compression, a rectal examination will be helpful to look for the sphincter tone. And then in sensory examination, when we are doing the sensory examination, we have to find whether there is any sensory loss in specific dermatomal distribution. For example, if a patient has a cervical radiculopathy, when we are checking, we should look for whether they have sensory loss just over the deltoid area. Like here, if that is the case, they have C5 radiculopathy. If they have sensory loss in the thumb and index finger, more towards the lateral forearm, they have C6 radiculopathy. If that is a middle finger, they have C7 radiculopathy. And if it is the last two fingers, it is the C8 radiculopathy. And if it is kind of a medial arm, then T1 radiculopathy. So assessing the sensation, specifically looking for dermatomal distribution, will be helpful to point which nerves are getting affected. And in the leg, again, we can check for, as you can see, L1, L2, L3, and L4, L5, and S1. So the most common things that we see are with the L4, you expect numbness over the anterolateral aspect of the thigh, whereas if it is L2, L3, which is not a common thing, those things actually cause more towards the groin. And L5, you expect sensory loss, kind of in the first dorsal toe here, in the interspace between the first and second toes, and it's a deep peroneal distribution. Also, they have the loss of sensation over the anterolateral aspect of the leg. Whereas with S1, you expect the sensory loss in the lateral foot distribution. So those dermatomal sensory loss will help us to point which nerve roots are getting affected. And so again, I'm going to talk more about like the findings which will be helpful to point to a specific nerve root level. As I told, like if it is a C5, which happens with a disc coming out between C4 and C5, it can cause deltoid weakness, and biceps reflex will be down, because biceps is actually a C5, C6 innervated muscle. So you expect some decrease in the biceps reflex, and the sensory loss will be over the deltoid area. That is the typical C5 radiculopathy. And with the C6, the sensory loss will be in the distribution of lateral aspect of the forearm, the thumb and index finger, and the brachioradialis reflex will be down. And you expect weakness with wrist extensors, because most of the wrist extensors are supplied by the C6, but you can also see some pronator weakness, because pronator teres is supplied by C6 too, and there will be some weakness of wrist flexion too, because some of the wrist flexors are supplied by C6 nerve root, but the main predominant muscles will be wrist extensors. The next one is C7. If there is a disc protrusion coming between C6 C7 pushing on the C7 nerve root, you can see the changes in the weakness will be predominantly in the wrist flexors and finger extensors, because the finger extensors are also supplied by the C7 nerve root, like extensor indicis proprius, extensor digitorum, those things, those muscles which supply the extensors of the fingers, they get affected. So in C7 radiculopathy, there will be weakness of wrist extensors, finger extensors and wrist flexors. And the reflex abnormality for C7 will be the triceps, right? Because triceps is predominantly innervated by C7, and the sensory loss will be in the middle finger. With the C8 radiculopathy, we expect the weakness is going to be mainly in the hand muscles, because most of the hand muscles are supplied by C8 nerve root, and there is no specific reflex we can check, because all those are kind of intrinsic hand muscles, but the sensory loss we expect in the medial hand distribution. And then coming to the back pain with radicular symptoms, if it is the disc between L3, L4, we expect to see the changes in the L4 nerve root distribution. So there will be some weakness of the quadriceps. That's the main thing, but you can see some weakness in the tibialis anterior too, as it is also innervated by L4, even though it is a good L5 nerve root muscle too. And you will expect a decreased reflex at the knee, and the sensory distribution will be in the medial leg. Whereas with the L5 nerve root compression, you will have weakness in the extensor digitorum longus. So there will be weakness of the dorsiflexion of the foot. They will have difficulty walking on the heel, and they will also have weakness of the other muscles, like other peroneal and tibial innervated muscles. So you will see weakness of the foot dorsiflexion, foot inversion as well as eversion, because both peroneal as well as some of the tibial innervated muscles have L5 nerve root supply. So you will see a foot weakness, mostly a dorsiflexion weakness, and there is no reflex abnormality with L5, because the ankle reflex is actually a measure of S1, but you will expect the sensory loss in the dorsal foot between the first and second toes. That is L5 radiculopathy. And then with the S1 radiculopathy, the muscles that get affected is gastrocnemius, and they will have weakness of the foot plantar flexion, so they will have difficulty walking on the toes, and they have diminished ankle reflex, and the distribution of the sensory loss will be lateral foot. So, so far we discussed about specific nerve root compressions and those findings. So when we are examining the patient, we specifically look for whether there is any specific nerve root getting affected in these patients, like back pain or neck pain. And then I'm going to briefly talk about if there is a compression of the spinal cord, what are the findings we are going to see. So it depends on from which side of the spinal cord getting pressed, whether it is a posterior cord or anterior cord or central cord. So the patients will have different presentations based on from which side the spinal cord is getting pressed. The posterior cord compression usually causes loss of vibration and proprioception, but they will have preserved motor function because the spinal cord, the posterior aspect of the spinal cord is predominantly a sensory component is there, like dorsal column, medial lemniscal fibers, whereas the lateral corticospinal tracts and anterior corticospinal tracts are here, so you don't expect to see much of the motor weakness if it is just a posterior cord. So posterior cord compression causes predominantly a sensory loss, and they can have some bladder dysfunction, and we see posterior cord mostly in vitamin B12 deficiency because of those posterior columns getting affected. Whereas if it is anterior cord syndrome, as happens with a anterior spinal artery infarction, like a sudden spinal cord ischemia from an atrial fibrillation or something, that usually produces an anterior cord syndrome. And also sometimes the disc herniations usually produces anterior cord syndrome. And with anterior cord syndromes, what happens is these fibers in the anterior portion gets affected. So that involves the corticospinal tracts and also the ventral spinothalamic tracts, which carry the sensation. So you see both legs getting weaker, and also on both sides you will have sensory loss because the ventral spinothalamic tracts, which carry the pinprick sensation, pain sensation, getting affected. Whereas the posterior columns actually carry the vibration and proprioception sense. So in posterior cord syndromes, you expect vibration and proprioception loss. And then central cord sometimes happen from syringomyelia or acute injury when there is a pressure from cervical spondylotic myelopathy. You will expect to see central cord syndrome. And the central cord syndrome actually affects the fibers, which actually from the lateral corticospinal tract and anterior corticospinal tract, the fibers come into the gray matter here. So this gets affected, so they will have more motor weakness, but they have intact sensation. And then there is a Brown-Sequard syndrome when there is a one half actually gets affected, as happens with patients who have multiple sclerosis and those things, but you will expect to see some weakness and vibration and proprioception loss on the same side, whereas pain and temperature loss on the other side, because ventral spinothalamic tracts cross, so you will expect to see pain and temperature loss on the other side. So those are the spinal cord syndromes, but as I told you, the most common causes, if it is a cervical spondylotic myelopathy, we will see anterior cord syndrome. And if it is a vitamin B12 deficiency, it's a posterior cord syndrome. Central cord syndrome, yeah, sometimes can happen with spondylotic myelopathies. And then I'm going to talk about another two very important syndromes here. One is conus medullaris syndrome and Cauda equina syndrome. So these are the main things. I mean, if you miss Cauda equina or conus medullaris, they are kind of emergencies and they lead to significant disability for the patients. Conus medullaris syndrome happens because of the tip of the spinal cord getting affected. It is at around L1 level, and the conus medullaris actually supplies, it supplies almost all the sacral nerves. So you expect to see, if there is a compression on the conus medullaris, you expect to see first the bladder problems and rectal dysfunction, and they have saddle anesthesia, so they lose the perineal sensation and they cannot feel around the anus. And they can have some upper motor or lower motor neuron symptoms too, but predominantly bladder bowel dysfunction, saddle anesthesia is characteristic for conus medullaris. And the conus medullaris can happen with disc herniation if it is a higher disc, and sometimes it can happen with a tumor or trauma. And then the other one is Cauda equina syndrome. That happens because of Cauda equina is basically the big bunch of the nerves which are coming down in the lumbar spine from all the nerve roots from L1 to S1. So all those nerve fibers can get affected when there is a large disc protrusion or something, and that leads to multiradicular pain. So they will have, in all the distributions, they will have pain. They have leg weakness and sensory loss, and also reduced deep tendon reflexes, both ankles and knees. And also later they will have bladder and bowel dysfunction. So it's kind of a broad compression of all the nerve roots, and because all the nerve roots clump put together in the lower part of the spine after coming from each spinal level. So if there is a big disc protrusion or something, or if there is a tumor or metastasis or infection, it can press on all those nerve roots and can cause a broad changes like significant weakness in both lower extremities, sensory loss, reduced deep tendon reflexes, bladder bowel dysfunction. That's a Cauda equina syndrome. So when we are examining the patient, I think a proper neurological examination is very important in these patients to make sure that we are not missing a spinal cord compression or a nerve root compression. Nerve root compressions are at least we can wait on those things, but spinal cord compressions and Cauda equina and conus syndromes they can lead to significant disability, and if we miss these things, it's I think big risk. So this is an example showing, as you can see, there is a broad disc protrusion, and all these nerve fibers, they're kind of clumped together. This is the Cauda equina there, and that's a Cauda equina syndrome. So a broad-based disc can cause Cauda equina syndrome. And this is an example of conus syndrome, the lower part of the spine here. This one is the conus here, getting pressed by, I think this is an ependymoma or something like that. There is a tumor pressing on the conus. So coming to the back to the just a picture of what we need to do in examination. First, we look for spine tenderness, spine deformity, spasm, trigger points by inspection and palpation, and we do range of motion, check for the range of motion, and then we check for any neurological, like any specific nerve root distribution dysfunction, or whether there is any signs for spinal cord compression with motor examination, sensory examination, reflexes, and gait examination. The additional test that will be helpful is a straight leg raise testing. What we do with that is actually make the patient lie down, and you raise the leg all the way up, and at the end you make the foot to kind of a dorsiflex. That creates compression on the nerve root, and if the pain happens around like 60 degrees, or then we can say that there is a nerve compression there. So the next thing I'm going to talk about, so we obtained the history from the patient, we examined the patient. So looking for any specific nerve root compressions or spinal cord compression, whether there is any conus medullaris syndrome, Cauda equina syndrome, and all those things. And then what are the things that makes us to worry, and to decide whether to refer immediately or whether we can wait. So we need to, I'm going to talk about those things. So first thing is always we have to pay attention for whether the patient has cancer, immunodeficiency, HIV, because those patients are at risk for malignant metastasis causing compression and also prone for infection. So we have to pay attention to that. So those are the things like a epidural infection or epidural abscess, epidural hematomas. Those things can cause an acute onset of the pain without trauma. And then compression fractures, patients who has osteoporosis are very prone for compression fractures. So those are the things that we need to think about. They need immediate referral. And this is an example where you can see a fracture. This is a traumatic fracture of the thoracic vertebra causing compression of the spinal cord. And this is an example for a spinal AV fistula causing prominence of the veins here. And this is also an example for AV dural fistula. And then you can see spinal tumor pushing on the spinal cord here. This is an example for transverse myelitis. You can see the changes in the spinal cord here. And this is an example where an infection can progress like a discitis, leading to vertebral osteomyelitis causing compression. So those are the things, I mean, epidural abscess, epidural infections, compression fractures, metastasis causing compression. All those things are emergencies. And so any patient who present with acute onset neck and back pain, and on examination or based on history, if you think there is myelopathic symptoms, we should treat them as medical emergency. And we evaluate those patients with the MRI scan. And if the patient, if we cannot do the MRI scan, then they need to go for CT myelography. So for example, if a patient, if on examination has a sensory level at T5, can have a cord lesion in the thoracic spine, but because usually what happens is the sensory fibers, they cross and they come down. So sometimes what happens is the patient may have a sensory level at T5 or something, but the actual compression could be upstream in the cervical spinal cord. So always when you see, for example, when you point to a T10 or T5 level, it's always it's recommended to obtain a cervical spine MRI too, because the compression could be higher, because these the ventral spinothalamic fibers, they cross down few levels and can go down. So patient may have sensory loss here, but the compression could be higher. So that's why I think a cervical spine MRI is needed even if you are suspecting a thoracic lesion. So MRI scanning or CT myelography is a must for any patient who present with myelopathic symptoms. So these are the recommendations from AAN. So as I told before, if the patient has a history of cancer, immunodeficiency states, who presented with an acute onset of the back pain or neck pain with spinal cord signs or symptoms, they should be urgently evaluated. That means an emergent MRI or CT myelography to make sure that they don't have spinal cord compression. I mean, if they have myelopathic symptoms, of course they have spinal cord compression, but those patients need to be treated as fast as possible. But if there is a subacute or ongoing symptoms suggestive for spinal cord compression, those patients, they recommend at least within 72 hours we should be able to get a scan, and at least within 72 hours we need to evaluate these patients. But in patients who has kind of a neck back pain, but there is no, that too particularly after lifting or after doing activities, without any sensory or motor or reflex changes or very mild changes, a conservative management for 10 to 20 days is recommended. But if those patients come back with more symptoms suggestive of neurological compromise, then spinal imaging is indicated. And if you're if you see a patient with a back pain or neck pain, and after lifting or after doing some activity, and if they have signs or symptoms suggestive for a radicular compression, those patients needs within 2 weeks an evaluation. EMG does not show the findings that soon. Actually, you have to wait at least 3 weeks before we can see some changes in the EMG. So ordering EMG acutely won't be helpful. So if you are suspecting radiculopathy, yeah, we need to see maybe in 2 or 3 weeks, and EMG later if we think if it is really needed. But those patients can be seen in 2 or 3 weeks. And the other thing is, if the patient has a back or neck pain, and we do some conservative treatment, but they have slowly progressive or unrelenting pain, then those patients should be, again, we need to do something faster. So those are the recommendations. If you are seeing acute onset spinal cord injury, immediate evaluation. But if it is a subacute onset, within 72 hours. If it is just a nerve root signs or symptoms, I think we can do within 2 weeks. So far I talked about history, examination, and red flags, and when to refer. Any questions so far? So we are going to do some questions and cases. And there will be 2 questions which I'm going to just discuss briefly, and then there will be 5 questions you can answer. Let's see whether we can do well on that. The first question is, so a 42-year-old previously healthy man presented with symptoms of neck pain, kind of radiating into the shoulder and arm with numbness in the left hand. And this happened after lifting a heavy box at work, and pain actually got worse with neck extension and coughing. On motor examination, he has weakness of the triceps, wrist extension, and pronation. Sensory examination shows numbness to pinprick in the left middle finger. His reflexes are normal except for absence of left triceps reflex. It's a classic radiculopathy findings they gave, but usually that we don't see that commonly in the patients. So you can see here, this patient actually came with kind of a pretty acute onset of the symptoms: neck pain, shoulder pain, arm pain. And so if you think about like acute onset of the pain and aggravating alleviating factors is getting worse with neck extension and coughing, indicating a radicular symptomatology. He does not have any walking difficulties, bowel bladder problems. So, I mean, there is no concern for spinal cord compression. So this is a case where a patient presented with kind of a acute to subacute pain associated with some radicular symptoms. And on examination, he has involvement of the neurological involvement with reflex changes, sensory examination findings, and motor examination findings. So that's a typical radiculopathy. And if you see, the weakness is in the triceps and wrist extension and pronation, and the sensory examination is in the left middle finger, and the absent reflex is the triceps. So that's a C7 radiculopathy. So the diagnosis is acute cervical radiculopathy at C7. And what are the likely etiologies? And this happened after lifting a heavy box at work. So most likely it's because of a probable disc herniation pushing on the nerve root. And what's the recommendation for the treatment? So far, I mean, when we discussed when we can refer this patient, I think we can refer this patient in like 2 or 3 weeks. So radicular symptoms, we can wait for 2 or 3 weeks. And usually what we do is we can try some pain medications, NSAIDs, muscle relaxers, and they can do activities. But usually in acute phases of cervical radiculopathy, I mean, I don't recommend physical therapy because sometimes it can worsen the symptoms. So we will wait until symptoms get better, and then we can send for physical therapy where they can do some stretching exercises and all those things. And we can perform EMG just for the sake of diagnosis, but we know just based on the examination. So we don't really need to do EMG, but that will be helpful for a confirmatory testing. And so this is the C7 radiculopathy. MRI of the cervical spine or referring the patient to a neurologist one can consider. So the next question is, this is a 59-year-old woman who is steroid-dependent asthma. So that means the patient is on long-term steroids, so she probably has osteoporosis. And she presented with sudden onset mid-back pain after a coughing spell. And the pain actually is kind of radiating to both the hips and posterior legs. And she also has involvement of the bladder since the onset of the pain. And when you do examine, there is a percussion tenderness over T12 and a limited range of motion. And her other examination is negative for straight leg raise testing, but she has difficulty walking on her toes. So she presented with a sudden onset of the back pain without any trauma, and she's at risk for osteoporosis because she's on long-term steroids. There is walking difficulties, there is bladder and bowel problems, but there is no specific nerve root distribution symptoms or signs. So this patient most likely has a compression fracture pushing on the spinal cord. And as you can see, this case represents a potential neurological emergency because most likely there is a fracture and pushing on the spinal cord, so she needs to be evaluated as soon as possible and she needs to be seen by a spine surgeon. So the next things we are going to do questions for you. So radicular pain is similar to referred pain, except that it is associated with numbness in a nerve root distribution. It is more intense in severity. It may be associated with motor weakness. It worsens in the distribution of specific nerve root with cough or valsalva and worse, all of the above. So you can please, if you can answer the question, we can get a bars here. We're still, somebody is answering still, so. So far, 19 responses. Let's see. So pretty good. I mean, 63% answered yes. So, I mean, I'll just go over the question again. So the difference between radicular pain and referred pain is radicular pain means there is a nerve root compression, whereas a referred pain means, yeah, there is a back pain or neck pain, but it is kind of referred to some area. For example, if it is a back pain, they may have some pain in the thigh or some pain in the leg, because the spinal cord also represent these areas here, so they will have some referred pain there, but it is not a nerve root compression. So that's the major difference. And so radicular pain is definitely associated with numbness, more intense pain. They have weakness, and it can worsen with coughing or valsalva maneuver. So all of the above is the right answer. So the next one, a 45-year-old man who presented with 3-week history of low back and left leg pain. Pain radiates into the left first toe when he bends forwards or cough. On examination, he has weakness of the left foot and first toe dorsiflexion and numbness in the left distal lateral calf and dorsum of the foot. His knee and ankle reflexes are normal. And which of the following is the most likely diagnosis? So this patient actually presented with the kind of a back pain which is going on for the 2 or 3 weeks, and also the pain is going into the left leg, into the left first toe. When he bends forward or coughs, it gets worse. And he has weakness of the toe dorsiflexion and numbness in the left lateral calf. So Let's see. Boy. So I think there is maybe some confusion between L4 and L5 radiculopathy. This is not a lumbar strain because the patient actually has the symptoms kind of radiating into the leg, and they have some dorsiflexion weakness, numbness. So there is a specific nerve root compression. So the question is whether that is a L4 or L5 nerve root compression. And patients who has L4 nerve root compression will have more weakness of the quadriceps and diminished knee reflex, whereas L5 radiculopathy, they have weakness with the dorsiflexion, toe dorsiflexion, and sensory loss in the foot. So this is basically, it's a left L5 radiculopathy because the patient has weakness with the foot and first dorsiflexion, and numbness in the left distal lateral calf and dorsum of the foot. As I said, like with L5 radiculopathy, there is no specific reflex we can check. It is the L4 which causes diminished knee reflex, whereas S1 causes diminished ankle reflex. But with L5, unfortunately, we can't check a reflex, but so that's why his reflexes are normal. So it's a L5 radiculopathy. So this patient needs like probably a scan, or you can consider referral to a neurologist within 2 weeks or 3 weeks or something like that. So the next question, 58-year-old woman who has history of metastatic breast cancer to the lung, and she presented with a 3-day history of worsening upper back pain, weakness of both the legs, numbness from her chest down, and the following are true except. So there is 3 correct answers here, only one is missing. So which one is the one which is not the right one? So she does not need to be treated as a medical emergency. She is likely to have a compression of her cervical or thoracic spinal cord. She may develop bowel or bladder incontinence, and she will require an emergent MRI scan of the spine. So if you could please answer. That's pretty good. So we are able to recognize the spinal cord compression, it seems, for sure. So that is, as you can see, this patient has cancer, so most likely she's at high risk for a metastasis, vertebral metastasis causing compression of the spinal cord. And she has this worsening upper back pain, weakness of both the legs, numbness below. So that's a typical spinal cord compression. So it has to be treated as a medical emergency. And she needs a emergent MRI scan, and she will need high dose steroids. She needs to be seen by a spine surgeon. So yeah, the spinal cord compression is likely. She may develop incontinence. She requires MRI. All those are the right answers, and it is an emergency. So the next question is a 49-year-old obese man, and he presented with 2-day history of low back pain radiating into both buttocks and posterior thighs. And the pain is worse with prolonged sitting or standing, but improved with ambulation. Cough or strain causes minimal increase in the pain. Examination, there is some tenderness in the back, and there is some muscle spasm. His neurological exam is completely normal. And the following are true, except one. The patient can be treated conservatively for pain for 10 days. and he most likely does not have a nerve root injury. He most likely has a lumbar degenerative spine disease with referred pain to posterior legs and buttocks, and the patient needs an emergent MRI scan of the lumbar spine. So which one is the right answer here? So the thing is, all of these are true except one that goes with the case. What? Yeah, that's right. Pretty good. Yeah, I mean, this guy is obese. He's kind of, sitting there having back pain. There is some muscle spasm. There is some palpation tenderness there. But he doesn't really has a nerve root signs or symptoms. It doesn't seem like there is a nerve root compression. There is no spinal cord compression. He does not need an emergent MRI. This guy can be treated conservatively for 10 to 20 days, and there is no significant nerve root injury. And most likely he has lumbar degenerative spine disease. That's why he's having some muscle spasm, tightness there. And so let's go to the next question. A previously healthy 35-year-old woman who presented with 1 week history of progressive weakness in both legs. She has clumsy gait and episodes of urinary urgency and occasional incontinence. She has tingling and numbness on her left side from an area just below the left breast down to her foot, which is worse with neck flexion. And she notes a nagging chronic pain in her lower back since a motor vehicle accident happened 6 months ago. On examination, she has weakness of right hip and knee flexion, right foot drop. Reflexes are hyperactive in both the lower extremities with Babinski on the right. Sensory examination is consistent with a T5 sensory level. Her gait is stiff-legged and spastic. All of the following are true except MRI or CT myelogram must include cervical and thoracic spinal imaging because the lesion in the question could be at a thoracic level or above. MRI or CT myelogram should be adequate to identify the pathology in question. Patient's chronic low back pain is likely to be of non-neurological origin and unrelated to her current symptoms of leg weakness and numbness. Patient history and examination are consistent with an acute myelopathy and should be treated as a medical emergency. It's a tricky question. That's perfect. We got the right answer here. So I have to go back here to explain here because I think in this one they didn't mention the whole thing. So you can see here this patient classically presented with signs and symptoms and signs of spinal cord compression. So it has to be treated as a medical emergency. And as I told before, even though the level is at T5, she needs to be evaluated for the cervical spine too, because even though the sensory level is here, the compression could be upstream. So a cervical spinal cord MRI should be done too. So that's why the first one is true. MRI or CT myelogram must include cervical and thoracic spine. The second one is wrong because MRI of the thoracic and lumbar spine should be adequate to identify the pathology, but it's not adequate. We need to get the cervical spine MRI too. So that's the answer. And she probably has a chronic low back pain based on history, and she has acute myelopathy and she needs to be taken care emergently. So the correct answer here is B. Thank you. And any questions or comments? Well, thank you for your attention.